Okay, let me seize this opportunity to thank the officials of BioRTC for the foresight of coming up with the initiative. I think it will greatly have a positive impact on research in clinical neuroscience as well as improve clinical outcomes. Let me also seize this opportunity to commend Dr. Mahmoud for coming up with such a beautiful initiative and to also thank our foreign collaborators for believing in us. Let me use this auspicious moment to thank our mentor, Professor Marty, for being part of this laudable initiative right from its inception. And let me also seize the opportunity to highlight some of the factors that could be of great importance in clinical neuroscience practice in sub-Saharan Africa, with specific emphasis on neuropsychiatry or cognitive neuropsychiatry in Nigeria. I've been a clinician and I've been practicing for the past 20 years in the sub-region, and I've worked with the Federal Neuropsychiatric Hospital, which subserves the northeast sub-region of Nigeria with a population of over 22 million people. It's the only hospital that has the capacity to do that in the sub-region. However, there are great numbers of patients that we've seen with cognitive impairments of varying intensity. And among elderly people of 60 years and above, the commonest disorders seen among them after depressive disorders or cognitive affective disorders are neurocognitive disorders. In a hospital audit that we've conducted just recently, since the inception of the hospital, over 3,200 adults with above the age of 60 were seen, and about 1,400 of them have cognitive disorders, of which 756, as earlier highlighted, constituting about 24% have Alzheimer's disease. Others that follow closely are vascular dementia, HIV-related dementia, and dementia in Parkinson's disease, as well as Lewy body dementia. What are the peculiarities militating against clinical practice in this area? I think is an important area I think I should mention. Clinical diagnosis is essentially clinical. We don't have facilities for neuroimaging such as PET or functional magnetic resonance imaging that will be used in aiding diagnosis. And therefore, you just make diagnosis based on clinical imperatives, using the syndromic approach and using the mini-mental state examination to ascertain cognitive impairment. Apart from that, diagnostic biomarkers or histochemistry are virtually non-existent in the diagnosis of cognitive impairment in sub-Saharan Africa. And this is not restricted to Nigeria alone, but so many sub-Saharan Africa, apart from probably in South Africa and maybe in the northern fringes of Africa. Another area that is of critical importance is that access even to cognitive treatment is a major problem, because most of the patients of elderly age are usually in the rural areas, while most of the facilities that exist for the treatment of cognitive disorders are mostly in the urban areas. And this makes accessibility and availability of the treatment to the patients a very huge problem. More so, even if they are diagnosed, the treatment outcomes are restricted, because in terms of pharmacotherapy, most of the drugs available for intervention are mostly the acetylcholine and stress inhibitors. Newer drugs that have been proven to be efficacious are not available in this sub-region of the world. By and large, why I try to bring up these issues is to show that there's a large treatment gap that still exists. And we have a huge patient population that will be explored to actually improve treatment outcome based on research and intervention initiatives. Let me thank the BioRTC for such a great initiative and looking forward to extending our unclenched fist for collaborations. Thank you.